О.О.Богомольця National Medical University, Department of Internal Medicine number 1. Respiratory system, palpation of the chest. Palpation of the chest, we should begin from the supraclavicular region. We should put our hands in such way and we make such movement for palpation of the chest. During palpation, chest in supraclavicular region should be moderately resistant and painless. We should ask patient to inform us if he feels some pain. Then we should assess supraclavicular lymphatic nodes. Normally, supraclavicular lymph nodes are not palpable. Then we should palpate collarbone and assess its integrity and painfulness. Then we go to the subclavicular region. Normally, the chest in subclavicular region is moderately resistant and painless. No lymphatic nodes should be palpated in this region normally. Then we ask patient put his hand behind the head. Then we go to the axillary region for palpation. We should place our hands high in the axillary region. And we should make such movements. In this region, the chest normally moderately resistant and painless. Then we should assess axillary lymphatic nodes. We ask patient to relax his arm. And in such way we perform the palpation of axillary lymphatic nodes. Normally, lymphatic nodes are not palpated in the axillary region. Then we do the same in the right side. Then we perform palpation of the posterior surface of the chest. We should begin from the suprascapular region or region supraspinata. In this region, people have developed muscles. That's why suprascapular area is more resistant than other areas of the chest. Then we go to the interscapular region. For this, we ask patient to cross his hands in front of him. We should place our hands in such way. Interscapular region should be palpated in the upper, medium and lower interscapular space. Normally, the chest in the interscapular region is moderately resistant and painless. Then we should palpate subscapular area. For more comfortable palpation of subscapular region, it is better way for doctor to sit near the patient. So we place our hands in such way and perform palpation. Normally, the chest in subscapular region is painless and moderately resistant. After palpation of the all regions of the chest, we should assess the resistance of the chest in general. We place our hands in such way and make such movement. Then we assess the lateral resistance of the chest. The chest in general moderately resistant, and intercostal spaces are moderately resistant. Then we should assess the painfulness in the Valais points. It helps us to differentiate the causes of the pain in the chest. Does the pain caused by heart disease or by intercostal neuralgia or by myositis? Painfulness in Valais points should be detected along the parasternalis line, along the medium axillaris line, and along the paravertebral line. We should place our fingers in such way that we press to lower part of the ribs. We should ask patient about painfulness. Along the medial axillaris line, we place our fingers in the same time in the few intercostal spaces for assessment painfulness in the Valles points. Then we assess painfulness in Valles points along paravertebral lines. Normally, no painfulness should be detected in Valles points. After that, we should assess voice resonance or vocal fremitus. We should begin from the supraclavicular region and go to the all region that we assessed before. We should place our hands in such way. And we ask patient to say loudly such words like Scooby-Doo or Ararat. We should change position of our hands to understand either the sensitivity of our hands is changed or there is a difference of vibration in these both regions. We should check voice resonance in all regions of the chest. Then we ask patient to put his hand behind his head for checking voice resonance in the axillary regions. We assess voice resonance in the suprascapular region. Then we should assess vocal fremitus in the interscapular region, and then we should assess the vocal fremitus in the subscapular region. Every time when we change position of our hands, we should ask patient to say Scooby-Doo or Ararat. We should perform investigation of voice resonance in all regions of the chest, and normally it should be the same in the all symmetrical regions of the chest, and it should be the same in the both sides. Comparative percussion of the lungs. We should start from the supraclavicular region and we should perform the comparative percussion on the symmetrical areas of the both sides of the chest. For comparative percussion, we should use indirect type of percussion, but only percussion of collarbone should be performed with direct type of percussion without finger plesimeter. On the clavicle, we perform comparative percussion to second intercostal space because of heart that is located lower. Then we perform comparative percussion only in the right side of the chest in such way. For percussion in the axillary regions, we ask patient to put his hands behind his head. We should remember that in the left axillary region, the stomach bubble gas is projected, and in the right axillary region, the liver is projected. These organs can influence on the sound that we receive during percussion. We place our finger plesimeter high in the axillary region. Then we should perform the percussion of the posterior surface of the chest. We begin from suprascapular region. Then we go to the percussion of the interscapular area. We should perform comparative percussion in the upper, medium, and lower area of the interscapular region. We have two types of percussion of interscapular area. First type is percussion along the spine. Another type of percussion is like fir tree. Then subscapular region. Topographic percussion of the lungs. Determination of the height standing of the lung apex. It should be determined in the anterior and posterior surface of the chest. In the anterior surface, we should place our finger plesimeter in parallel to the collarbone. We should make percussion to the top to receive dull sound. The position of lung apex should be determined near the edge of finger plesimeter faced to the clear pulmonary sound. This rule is universal for topographical percussion of the chest. We can determine that height of standing of the apex of the lungs is 4.5 centimeters above the collarbone. Determination of the apex lungs in the posterior surface should be begin from the finding of 7 cervical vertebrae. We should place our finger plesimeter in parallel to the scapular spine. And we should perform percussion in toward to the 7 cervical vertebrae. And near the edge finger plesimeter faced to the clear pulmonary sound, we can find the height of apex of the lung in the posterior surface. Normally it should be in the level of the 7th cervical vertebra. Determination of the lower borders of the lungs. In the right side of chest, it should be determined along such lines as parasternal line, mediaclavicularis line, axillaris anterior, medium and posterior line, scapularis line and paravertebralis line. On the left side, we start percussion from the anterior axillaris line because of heart, and then we perform percussion along the same lines as for right side of the chest. We should begin from high position because we don't know where the borders are located. Percussion is performed in intercostal spaces. We should find absolutely dull sound and stop. It will be the lower border of the lung. And near the edge of the finger plesimeter faced to the clear pulmonary sound, we can determine the lower border of the lung. For determination of lower border of the lung, we should find the appropriate intercostal space or appropriate rib. For this, we should find angulus ludovici, the angle between manubrium sternum and corpus sternum. Near angulus ludovici, the second rib is jointed to the sternum. Then we go from intercostal space to next intercostal space in such way and calculate the ribs to find the rib according to the lower border of the lung. Normally, the lower border along the parasternalis line is located near 5th rib. Then we determine the lower border of the lung along the medioclavicularis line. The same method of determination of lower border of the lungs should be used along all other lines. Definition of the lower border of the lung in the left side of the chest that is performed along anterior axillaris line and along medial axillaris line has some particular features. Technique is the same, but we should pay attention on gas bubble of stomach. Because of it, we perform percussion from clear pulmonary sound to tympanic sound, not to the dull sound. And the last one, what should we do during topographical percussion? It is definition of the width of the traube space. Lying position of the patient is the better position for determination of traube space. Why should we do it during topographical percussion? Because the size of traube space may change in case of accumulation of fluid in pleural cavity. The doctor should pay attention if patient has some constant changes of the traube space. First of all, we should remember that size of traube space is determined in the 8th intercostal space. For finding 8th intercostal space, first of all, we should find the angulus Ledovice, where the second rib is joined to the sternum. And then we go from second intercostal space to each other before we find 7th intercostal space. Finger plesimeter is placed at the level of the 8th intercostal space along medial clavicular line perpendicular to the ribs. We should go from tympanic sound to its disappearing, to the left and then to the right. Normal width of traube space is 12 centimeters. Auscultation of the lungs. Auscultation should begin from the top and then we go to the bottom, as other methods of investigation of the chest. We put the stethoscope in such way that no spaces was between skin and membrane of stethoscope. We ask patient breathe through the slightly open mouth evenly and calmly. Why it is important? Because if patient has some problem with nose breathing, we can hear different sounds that go from the nose and we will think that it is added pulmonary sounds. We perform auscultation in the symmetrical regions of the chest. We should ask patient, please breathe deeply for differentiations of additional breath sounds. Also, we should ask patient to cough for differential diagnostic of additional breath sounds. Coughing and deep breathing are techniques that help us to make differential diagnosis of main and additional breathing sounds. Rails and crepitations may disappear or change depend on coughing and deep breathing, in spite of pleural friction rib that usually do not change depend on breathing or coughing. Then we go to the auscultation of subclavicular areas. We ask patient to breathe deeply. Because of heart, we usually do not perform auscultation of the left side of the chest of anterior surface of the lung. In the right side of the chest, we perform auscultation of the middle lobe of the right lung. Then we ask patient to cough again. For auscultation of axillary area, we ask patient put his hands behind his head. We put the stethoscope in high place in the axillary region. We ask patient to breathe deeply. Then we ask patient to cough. Then we perform auscultation of the posterior surface of the lungs. We should begin from suprascapular regions. We should perform auscultation in the symmetrical regions. We also ask patient to breathe deeply and to cough. For auscultation of the interscapular areas, we ask patient to cross his hands in front of him. We perform auscultation in the upper interscapular area, in the middle interscapular area, and in the lower interscapular area. Every time we ask patient to breathe deeply and to cough. Then we auscultate subscapular areas in the both sides of chest in the symmetrical regions. We also ask patient to breathe deeply and to cough. After finishing, we should perform the determination of bronchophony. Bronchophony is clear hearing of whispered speech. Normally, during bronchophony, we can hear just parts of the words, but if patient has some consolidation of lung tissue, we can hear the whole words. We ask patient to whisper such phrases like 1, 2, 3. Bronchophony is investigated in all points of auscultation of the lungs, and every time patients should repeat the words by whispering. Раз, два, три. Раз, два, три. Раз, два. Раз, два, три. Раз, два, три. Раз, два, три. Раз, два, три. For performing auscultation in the axillary regions, we ask patient to put his hands behind the head. Then we determine the bronchophony on the posterior surface of the lung. Thank you for your attention.